Now, movement disorders has essential tremor, Parkinsonism, restless leg syndrome, Huntington's disease, Tourette's, and multiple sclerosis in this section. An essential tremor occurs at both rest and with intention. And intention means that you're trying to do something, you're reaching for things. That's what intention means. Now, the tremor is greatest in the hands, but you can actually see people the next time you're walking down the street or sitting somewhere with their head bobbing. And it affects some manual skills, and particularly in the computer era, not being able to use a keyboard perfectly is a serious problem. Caffeine makes it worse, and beta blockers make it better. Just remember that the tremor at rest and exertion improve with a drink. I took 2 drinks, Doc. I felt better. That's the key to the diagnosis. The very definition of Parkinsonism is a loss of the substantia nigra. Now, this results in a decrease in dopamine, and that decrease in dopamine leads to a movement or gait disorder. Now, you may think that the major issue in Parkinsonism is the tremor, but the major issue for the patients is that it is a difficulty in getting from place to place as a movement disorder. Now, this is essential because when you want to answer the question most likely diagnosis, since there is no test for Parkinsonism, the diagnosis is entirely based on that clinical presentation. Look for a difficulty walking and orthostasis. You get lightheaded when you stand up, and that's the key to the diagnosis. On top of it, you'll have the tremor, but start first with gait and movement disorder. Most Parkinsonism is idiopathic. Older people slow down, they get a tremor, cogwheeling, orthostasis. Just happens. Head trauma makes it happen more. You ever wonder what the difference is between amateur and professional boxing? Well, there's 2 things. One is professional boxing uses an 8-ounce glove and no headgear. Amateur boxing uses headgear. The other difference is Parkinsonism. Professional guys get Parkinsonium after 5 to 10 bouts. Amateur guys need 25 to 50. That's the big thing. Level of head trauma. Antipsychotic medications such as Thorazine, well, really all of them could do it. The new antipsychotics do it less. So risperidol, ziprasidone, olanzapine, clonazepam do it less, but they all could do it. Encephalitis. Von Economo's encephalitis occurred after the First World War. Literally cooked little kids' brains. They were locked in from 1920 to 1955, 1960, until an experiment in the Bronx, home for the quote-unquote incurables at the time. A man develops dopamine, learns to synthesize it, gives it to them, and they woke up after 35 years of being immobile. Wow. Go see the movie, Awakenings. Reserpine can cook out your neurotransmitters too, and metoclopramide. And now it's not so much that we're using reserpine from moment to moment and day to day, but somebody who had reserpine 15 years ago, before we stopped using it so much, can be Parkinsonian today. Remember, the most common cause of Parkinsonism is idiopathic. Look for a person who's 50 to 60 years old. Everything's slowed down. Tremor, muscular rigidity, bradykinesia, meaning all the movements are slow. There's a shuffling and unsteady gait. Makes people fall down. Not only do they have a shuffling gait, they have autonomic instability. Sometimes that's called Shy-Drager syndrome. That is profound orthostasis with Parkinsonism. Cogwheel rigidity, the slowness of movement on passive extension or flexion of the extremity. And facial expression is limited. People think that they're just not showing them any love. They're not showing any emotion. Actually, I've heard the family members say, my God, my father acts like he doesn't care about me anymore. No, he's just Parkinsonian. He's Parkinsonian. He loves you. He loves you. He just can't show it right now. The writing is small and micrographia. Everything is small. Bradykinesia, rigidity, immobility, tremor. The key feature of Parkinsonism is a postural instability or orthostatic hypotension. When that is the only manifestation, that's called Shy-Drager syndrome. Now, in addition to that, you basically have an inability of your pulse and blood pressure to reset. When you stand up, when you sit up or stand, your heart beats faster to fill the vascular space. Your blood vessels constrict, and theirs can't. There's cogwheeling of your autonomic nervous system. So you get lightheadedness when getting up from a seated position. Now, if you said, listen, come on, Dr. Fisher, just give me, I just want to know the two questions. Just give me two questions. Okay, the answer is, most frequent Parkinsonian question is, treatment. You got to know the drugs. Mild disease is treated with anticholinergic medications which relieve the tremor and rigidity. Now, no one precisely knows why these work. You don't have dopamine. Why does getting rid of acetylcholine help? We don't know. But benztropine and trihexyphenidyl basically improve the person's circumstances, makes them more mobile, less rigid. Unfortunately, you can't use these drugs in people who are above the age of 60 and 70 because the adverse effects of dry mouth, of worsening prostate hypertrophy, well, it doesn't, not so much that it makes the actual gland grow, it's that it causes increased blockage by making the detrusor muscle immobile. So if you have symptoms of prostate hypertrophy, it worsens the symptoms of prostate hypertrophy and it makes you constipated. And all of these things are more frequent in older patients. So therefore, if you're 70 or 80, you don't want to use these drugs because the guy won't have a bowel movement for the next 3 weeks. He won't urinate for 2 weeks. In addition, what's the basis of dementia drugs? The basis of dementia drugs is drugs that increase acetylcholine. Acetylcholine forms memories. More acetylcholine helps dementia. Therefore, anticholinergic medications will worsen the dementia in older persons. Now that really sucks because who gets Parkinson's disease? Older people. Who needs the acetylcholine? Older people. What's the treatment for Parkinson's in the older people? Anticholinergics. Oh, that's no good. So you got to use these in younger patients so you won't get the side effects, particularly the memory loss. Now, that mild disease occurs in an older person, and you're nervous about the adverse effects of those anticholinergics. And remember, adverse effects are consistently always on a test. That's because they're clear. Which drug to use in some people with Parkinson's? The dopamine agonists or replacement with levodopa, carbidopa. Sometimes that's difficult. But the adverse effects of anticholinergics cause dry mouth, dry bladder, constipation, precipitate glaucoma, worsen dementia. That's super clear. That's why it's always on the test, because it's clear. Amantadine is not as strong as the anticholinergics, but amantadine in mild disease basically squeezes a little bit of release of dopamine from the substantia nigra, and it's definitely the answer in older persons. Older in this case is defined as being above the age of 60 who are intolerant of the anticholinergic medications. You see, Lewy body dementia is specifically the name given to Parkinsonism with dementia, whereas Shy-Drager is given to Parkinsonism that's predominantly with orthostasis. Severe disease is defined as inability to care for yourself. That means you can't cook, shop, clean, or work. If you can't get in and out of the subway, if you can't drive your car, you can't get to work, you're orthostatic. Dopamine agonists are like a light beer. They may be less toxic, but they're also slightly less effective. Less effective, less strong than levodopa, carbidopa. Dopamine agonists, ropinirole, pramipexole, bromocriptine, and cabergoline, which are older agents. You may recognize these from the fact that they're used for prolactinomas. The decreased prolactin release can be used there. Now, bromocriptine and cabergoline are efficacious, but bromocriptine and cabergoline as older agents are used less frequently because of adverse effects. But dopamine agonists are frequently the first choice in the treatment of severe Parkinson's because they have overall, as a class, less adverse effects than levodopa, carbidopa. The treatment of severe Parkinsonism
is with levodopa carbidopa. Now, it's very important because severe Parkinsonism means that a person simply can't take care of themselves. They can't walk down the street, they can't carry things. When they get up from a seated position or from lying down, they get orthostatic and become syncopal or pass out. This is the single most effective medication for Parkinsonism, but also has the most amount of adverse effects, on-off phenomena. On-off phenomena means sometimes you suddenly run out of dopamine and you become rigid and immobile, or suddenly you have too much and you become nauseous and have abdominal pain or dystonic motions. Now, these insufficient episodes of off, characterized by bradykinesia, or the on effect with too much dopamine resulting in dyskinesia, simply can't be predicted. So, levodopa carbidopa may be the most effective medication for Parkinsonism, but it also has the greatest amount of toxicity.
When using dopamine replacement for severe disease, COMT inhibitors, tolcapone and tacapone, are useful exclusively to extend the duration of levodopa carbidopa. You can't use them by themselves. Basically, it's a dopamine extender. It blocks the metabolism of dopamine, and when you are not fully controlled with levodopa carbidopa, these are used only with them to make it so that they last longer. And when there's on-off phenomena, it sort of evens out the dopamine level over time, particularly when the response to therapy is inadequate. If you've ever seen or talked to someone who has Parkinson's, and they tell you they're walking home with a bag of groceries, and their dopamine replacement, levodopa carbidopa, wore off while they're crossing a large street and they became immobile, you will understand why this question on what drug do you add next to extend the length of time of the use of your levodopa carbidopa is a colossally important question. We have some other alternatives for severe disease. This is not as clear as to tell you when in the course of management they're given, but they're add-ons. MAO inhibitors, racegiline and selegiline, also can be used to extend the levodopa carbidopa, or as a single agent, or to adjunct it to the levodopa carbidopa. They also block the metabolism of dopamine. The ultimate treatment is to put electrodes into the brain for deep brain stimulation. This electrical stimulation that in some people can be highly effective as long as you don't mind electrodes going around in your brain. Now, with MAO inhibitors, tyramine-containing foods like cheese and red wine can be very bad. They can precipitate some very severe hypertension. So the hypertension can really happen instantly. You got to avoid those when you use those medications. 70-year-old man with extremely severe Parkinsonism comes to the emergency department with psychosis and confusion developing at home. Now, the key word here, highlighted and underlined, is extremely severe Parkinsonism. He's maintained on levodopa, carbidopa, ropinirole, tolcapone. What's the next step in this man who's developed psychosis on Parkinson's meds? And the answer is start clozapine. Clozapine is an antipsychotic. Clozapine is an antipsychotic, and the other one here could be quetiapine. Clozapine and quetiapine. But the major issue is, when you have such severe Parkinson's that you need all these meds, you cannot just say, stop the medications. You cannot just say, stop. The Parkinson's is so severe that if you stop the Parkinson's, this person will become locked in. They'll become locked in. And therefore, you've got to continue the medication. So this is rare. It's one of the few things where you actually say, continue a drug that has severe adverse effects. But when you have a person that without those drugs, they're locked in, and with the drugs, they're psychotic, you've got to treat the adverse effects of the meds. 40% of people who have Parkinson's develop psychosis when they're at the level of Parkinsonian medications that they need. In other words, 40% of people, the only way you can get them sufficiently controlled so that they're mobile from the Parkinson's is to give them so much medication they actually go crazy, psychotic, see bugs coming out of the wall with the Parkinsonian meds. Well, why not start haloperidol? Because it has much more adverse effects than the clozapine. The other thing is, What is one of the main effects of haloperidol? Why, it's Parkinsonism. And that's the problem. Look at the paradox here. Antipsychotic meds cause Parkinsonism, and Parkinson's meds cause psychosis. Yowza. But if you say, listen, the only way we can get you so that you can move is to give you enough Parkinsonism meds that you develop psychosis, then you treat the adverse effect rather than let grandpa go back to being frozen. Treat the adverse. Don't stop the Parkinson's meds. Spasticity refers to extremely painful contracted muscles. It's from an abnormal reflex arc. It's from damage to the central nervous system. It's often associated with multiple sclerosis. MS is multiple sclerosis. No single treatment is always effective, although baclofen, and here's something new for most of you, tizanidine, an alpha agonist may work. Now, spasticity is trying to imagine yourself in a long transatlantic flight in the middle seat, squeezed in between 5 really big people. And you can't move for 8 hours, and you feel very tight. But in this case, it goes on for the rest of your life. It's from an overactive reflex arc. Baclofen and tizanidine may open you up, but not always. It's very painful. Imagine contracting your muscle, squeeze, and hurts, it burns. It just doesn't stop.
Restless leg syndrome is a great name because the name implies the presentation. It's a person who has an uncomfortable sensation in their legs. They simply can't get comfortable. It happens worse at night. It's creepy and crawly sensation of things crawling over your skin at night that's relieved by moving your legs. The patient is often brought in by their bed partners being kicked at night simply because the only way the person can get comfortable is to suddenly move their legs. Now, this discomfort is worsened by caffeine and stimulants for unknown reasons and relieved by moving the legs. Now, we're not sure exactly what restless leg syndrome is, but we do know that dopamine agonists such as pramipexole have a tremendous efficacy. In the past, we used to use levodopa-carbidopa, and although we're not certain of the etiology, drugs that are used for Parkinsonism tend to work.
Huntington's disease is a hereditary disease based on a very clearly identifiable genetic defect, CAG, cytosine, adenosine, guanine, trinucleotide repeat sequences on chromosome 4. One of the great disappointments of genetic medicine and the expectation that there would be gene therapy is that disorders such as Huntington's, which have been known for a very long time, that once we knew the precise genetic anomaly, we'd be able to quickly cook up some gene therapy and fix it. That has not been proven to be true in any case. How do you answer the question, what's the most likely diagnosis? Huntington's disease is the answer when you see a choreiform movement disorder, dyskinesia. The reason it's called choreiform is it's from the same word as choreography, because when you see a choreiform movement disorder, it looked like somebody was dancing in space, their arms rhythmically moving like a snake. Choreiform movement disorder. You see it in a person with dementia and behavioral changes. The person looks like they're publicly drunk. So when somebody has Huntington's disease and they're wobbling around the street, losing their memory and acting irritable, moody, and antisocial behavior, the first thing a policeman does is he doesn't walk up and go, I bet you have CAG trinucleotide repeats and you have a hereditary genetic disorder presenting in your 30s and 40s. No, he says you're publicly drunk and arrests you. Its onset is relatively young, and there is really an expressed family history because it happens just after people give birth, and this is one of the few reasons to actually break confidentiality records of adoption. In other words, you give up somebody for adoption when you're 35, and when you're 40 you develop Huntington's disease. There's an ethics question for you. Is it ethical to break the confidentiality of adoption to reveal to the adoptive parents that the donor has Huntington's disease? And the answer is yes, because it's in the best interests of the child to know that they have hereditary disease. The diagnosis of Huntington's disease is based on the clinical presentation, the symptom triad of movement, disorder, memory, and mood, and confirmed by genetic testing. The genetic testing for Huntington's disease is amazingly accurate, 99% sensitive and 100% specific. That's about as good as it's going to get. The CT and head MRI might show caudate nucleus involvement, but these tests are not nearly as accurate as the combo of the clinical presentation and the genetic test. The most common wrong answer for Huntington's disease is to say that there's no treatment. Well, no treatment may reverse the Huntington's disease, and that's certainly true. But there's also no treatment that reverses and cures diabetes. But there's plenty of treatment, such as tetrabenazine for the dyskinesia. The dyskinesia is treated with tetrabenazine. And we have psychosis to be treated with haloperidol, quetiapine. And remember, quetiapine is our choice because it has the least extrapyramidal adverse effects, which is basically the ability to cause Parkinsonism. Tourette's is an idiopathic disorder. It's extraordinarily debilitating and extraordinarily frightening to the parents. Imagine that you have a beautiful little daughter who all of a sudden starts barking and grunting and sounds literally like an animal that cannot be controlled. It's horrible, incredibly depressing to the parents, particularly the motor tics of sniffing, blinking, frowning, and obsessive compulsive behavior. Remember, by definition, obsessive compulsive behavior means it is not something that can be reached by talk. You can't talk your way out of OCD. You can't say to someone, gee, you shouldn't be spending an hour arranging your shoes so that they're exactly parallel but don't touch. The person will say, I understand, but I can't help myself. That's why it's obsessive compulsive. By definition, if you can talk to people and they can change their behavior, it's not OCD. There is no specific diagnostic test for Tourette's, and it's a symptom complex that's treated with neuroleptics such as fluphenazine, clonazepam, pimozide. Haloperidol can be used, but as haloperidol has no greater efficacy and more adverse effects such as Parkinsonism and extrapyramidal symptoms, there's no reason to particularly use that drug over these other newer neuroleptics. Now, because an enormous part of the feature of Tourette's is attention deficit hyperactivity disorder, ADHD, the ADHD drugs of methylphenidate is incredibly indispensable to the routine treatment of Tourette's. So you should be expecting that for the behavioral issues to have neuroleptics, the ADHD problems to use methylphenidate, and if the motor tics are incapacitating and very distracting, you can use tetrabenazine the same as you would for a person who had Huntington's disease. Multiple sclerosis is an idiopathic disorder with exclusively involvement of the central nervous system of the brain and spinal cord. In the same way Guillain-Barré is exclusively involvement of the peripheral nervous system, Guillain-Barré never goes into the brain and spinal cord. MS is exclusively only in the brain and spinal cord. It's more common in Caucasian women living in colder climates. Now, is that because it's the cold that increases MS, or simply because over 1,000 years of migration, if you have MS, you get worse symptoms where it's warm? That's why it can be described as a person is weaker after they take a hot bath or hot shower. So you would emigrate to a colder country because you're more comfortable there. What is the most likely diagnosis is when you look for a person with multiple neurological deficits of the central nervous system. Although any aspect of the central nervous system can be involved, the most common presentation is optic neuritis. And that optic neuritis presents with blurry vision. That optic neuritis can present with any form of visual disturbance, its presentation, and also color vision problems. Get color vision problems, sometimes described as color desaturation. In addition, you get a blurry vision because the internuclear ophthalmoplegia is the inability to adduct the eye, meaning you can't bring it towards the center, cannot adduct one eye, and the other eye has nystagmus. So you've got an inability to bring one eye past the midpoint, and the other eye has nystagmus. The I&O is characteristic of MS. Very little else has that besides multiple sclerosis. Now, after optic neuritis, And it's not that it has to present with optic neuritis, which is unilateral loss of vision, unilateral loss of color vision. The most common abnormalities are motor and sensory, or motor or sensory. And you could have a person who's got weakness and it resolves, sensory disturbance and it resolves, optic neuritis and it resolves. It could be any one or all three of them. Now, in addition, people with multiple sclerosis present with very significant fatigue. These people are just out of gas, tired, tired, tired. And spasticity and hyperreflexia because you have an unopposed reflex arc in the spinal cord. And that spasticity is extremely uncomfortable. People has a feeling like being contracted all over. Cerebellar deficits also occur and people develop ataxia. Now, what is left intact? What's not touched with multiple sclerosis? The things most likely to be left intact are cognitive defects. You just don't get them very much. The most amazing thing is that despite a head that might be filled with white matter plaques, dementia is extremely rare and uncommon. Sexual dysfunction and dementia, even when there's enormous numbers of plaques, they just don't occur until very, very, very late. This is one of the reasons that multiple sclerosis doesn't actually shorten lifespan significantly. It just makes your life very uncomfortable, but doesn't shorten lifespan. Remember, optic neuritis is the most common presentation, then motor or sensory, and you have to know how to treat each of those additional findings: fatigue, spasticity, and hyperreflexia.
For multiple sclerosis, the MRI is both the best initial test and the most accurate test. If you look at the clear arrows here, those white lesions are simply not supposed to be there. The white matter does not actually look that white. It should be looking rather much darker, much more grayish like the rest of the tissue. This is both the best initial and the most accurate test simply because the level of false negatives on CT scan is far too great. CT scan can miss many of the lesions will picked up as an MRI. And the cerebrospinal fluid is not the most accurate test because the MRI is both more sensitive and more specific than oligoclonal bands.
Additional diagnostic tests for multiple sclerosis are the cerebrospinal fluid. The cerebrospinal fluid will show a mild elevation of protein and a mild elevation in white cells. Now, the major issue is that multiple sclerosis is diagnosed almost exclusively by MRI. However, a small number of patients have an equivocal MRI, and oligoclonal bands are used to be able to make the diagnosis in those who have an equivocal MRI. So what should I expect to find on that CSF? Oligoclonal bands means a few bands, a few groups of IgG. In myeloma, it's one clone. That's why it's called a monoclonal gammopathy. And in CSF and MS, it's oligoclonals because it's a few. Now, they're also not specific to MS. That's why this was never a great test. But when you have an equivocal MRI, what else can you do? Now, visual and auditory evoked potentials are always the wrong answer. They are tests in which you shine a light in people's eyes or sound in their ears, and you test the reflex arc. They play a recording of a baby crying and see how long it takes to cycle around through your brain. And if there's a delay to the neural pathway, it means, hey, you have an obstruction with a plaque. It's multiple sclerosis. There is one, and has always been only one therapy for acute exacerbations of multiple sclerosis, and the initial therapy and only therapy for the acute exacerbation has been high-dose steroids. Steroids shorten the duration of that exacerbation, increase the velocity to a recovery time. We have in the past, for extraordinarily severe cases, occasionally done plasmapheresis to take off the antibodies, and you can see it's so ineffective it's not even on these choices. When you see plasmapheresis, it's wrong. Choose the steroids. Your number one issue is to be able to distinguish between the drugs that are used for an acute exacerbation and the drugs that prevent relapse and progression. Now, the next list of medications may seem overwhelming to some of you because there's a lot of funny names there. However, if you had multiple sclerosis and you had not been controlled with glatiramer or beta interferon, you would think that knowing about medications like natalizumab, which would give you a chance of stopping the progress of your debilitating, horrible neurologic condition, you would not find it such a burden to learn the name of them. Mitoxantrone is a chemotherapy variant that is used now only for multiple sclerosis. Fingolimod, as well, as the honor of being the only oral therapy for multiple sclerosis. And dalfamperdine, I don't expect most of you to have even heard of that one. Dalfamperdine has been approved to increase walking speed in people who have multiple sclerosis. Azathioprine and cyclophosphamide have been used in the past, but they have much more toxicity without greater efficacy compared to these other medications. Glatiramer and beta interferon are the first choice, and that's why they're definitely on the top of this list. They are the first choice for prevention of relapse. A new MS treatment has started, and the MRI shows new multiple white matter hypodense lesions. What is it? The white matter lesions are progressive multifocal leukoencephalopathy, or PML. And what is the cause? The most likely etiology is natalizumab. You have multiple drugs. They all do the same thing, delay progression. How are you going to get questions? What is different and unique between them? Only one causes PML, natalizumab. Only one is for walking speed exclusively, dalfamperdine. Only one is oral, fingolimod.